Thank you, Dr. Sanjida, for your kind introduction. As the scheduled chairperson, Dr. J.R. Wadud is sick, so we are praying for his quick recovery. And with this, I'd like to start today's session on prevention of foot ulcer, role of vascular surgeon. Now, I'd like to introduce the speaker. The speaker, Dr. Saklayen Russel, is assistant professor and associate consultant, Department of Vascular Surgery, Ibrahim Cardiac Hospital and Research Institute. He is also working as president, social awareness for vascular surgery, and as joint secretary, Bangladesh Society of Vascular Surgeons. Dr. Saklayen Russel, over to you for your presentation. We are not hearing you. Probably you have to unmute the microphone. No, not audible.
I think it's audible now.
Yes, it is audible now, and slides are also visible. And you may go
Uh,
to the full screen.
my video will not work. I think audio is enough because
Okay.
this screen sharing is here.
Yes.
And thank you for giving me the opportunity to deliver my sharing experience regarding prevention of foot ulcer as a vascular surgeon. And I am working as a associate professor and head Department of Vascular Surgery, Ibrahim Cardiac Hospital and Research Institute. And this is my place where we are working as a vascular surgeon. And this is the newly constructed vascular complex of Ibrahim Cardiac Hospital and Research Institute. And again, thanks to our Borders Authority for giving us the opportunity to serve the patients in such a beautiful place. And these are our expert vascular surgeons working in our department, together with two visiting professors from home and abroad, Dr. Jim Ulcer and Dr. Mahbub Kudus. And Dr. Jumer Ahmed, he's working as the assistant professor and associate consultant. Dr. Laila Akhtar Jan, she is the registrar and specialist. And this is our staff, 32 staff dedicated for vascular surgery department. And this is the beginning of vascular surgery department of Ibrahim Cardiac Hospital and Research Institute. That is the sister concern of Ibrahim Borders, Bangladesh Diabetic Shamiti. We started our journey in April 2017. And at that time, the news was published in several media. So, and still in COVID-19 pandemic, our services are going on through yellow zone, green zone, red zone. And Ibrahim Cardiac Hospital and our department never postponed their services due to COVID pandemic, and we are doing all kinds of vascular activities, even in risk. Before going to my full presentation, let's have a look over the face of this old man. He was so happy because he got the chance to attend the Hajj pilgrims, and that is the dream of a Muslim. But during his Hajj prayer, he developed blister in his foot, and he was referred back to Bangladesh. And from airport, he got admitted in the Department of Vascular Surgery directly. bypass in his house. And here in our vascular surgery department, we diagnosed him as a case of impending septicemia. That's why he was shifted to ICU. From ICU, after his improvement, he was shifted to HDU, followed by again vascular surgery department for the management of his own. And this is the depressed face of this man. And don't forget to look at the second man. He's a doctor, and yes, he has same history, and he was performing his Hajj and again referred to our department for some of his leg problems. And see the patient. He was 65 years and presented with non-healing ulcer of foot. He developed blister on foot during Hajj. He performed Hajj with blisters, which ended with non-healing ulcer of foot. And with that ulcer, he was not able to move, not able to take bath regularly, even not able to sleep, even not able to pray properly. That's why he was depressed. He has feelings that his Hajj was not accepted by the Allah. That's why he was so depressed. And we diagnosed him as a case of vascular impairment with non-healing ulcer of foot. That's why that ulcer was not responding with ordinary treatment. Later on, we'll do vascular intervention, and Alhamdulillah, he was doing good. But we are sorry to announce that this man, he is a doctor, graduated from a government medical college. Ultimately, he lost his foot, and below-knee amputation was done because that foot was totally non-vascularized. We failed to vascularize the patient as the condition of the wound was not so good and didn't allow us to do any vascular intervention. So the question arises, what is ulcer? All of us, we have huge knowledge regarding what is ulcer. Let's share the definition from the books. Ulcer is the breach of continuity of skin, epithelium, or mucous membrane caused by sloughing out of inflamed necrotic tissue. What are the different types of foot ulcer? Here is some common foot ulcers. First off, our interest is on neuropathic ulcer. Sometimes we call it diabetic ulcer. Although diabetic ulcer is most of the time, it is associated with arterial or venous ulcer also. But we can speak separately as a neuropathic ulcer. This is the commonest cause of lower extremity amputation because of impaired sensation in the feet. Injury may go unnoticed and untreated, leading to an ulcer. And one in every 6 people with diabetes will have a foot ulcer during their lifetime. The arterial leg ulcer, these appropriate 10% of all leg ulcers, and they are due to insufficient arterial blood flow. And this is our main area of interest as a vascular surgeon, arterial leg ulcers and also venous leg ulcer. This is very much common in our country, and most of the time, this type of ulcers are neglected. Sometimes this is called stasis ulcer, but with the vascular surgeons, we call it venous leg ulcer. And this is the complication of chronic venous insufficiency that we call popularly named as varicose vein. And this type of venous ulcer never need any, most of the time don't need any antibiotic or any drugs. Local wound care is enough for the cure of these patients, that is venous ulcer. Usually diabetic foot ulcer is located bottom of the foot, especially head of the second and fifth metatarsal bones. Diabetic foot ulcers can affect one's quality of life. Venous ulcer are mostly occur above the medial malleolus, and arterial leg ulcer usually found in the heels, tips of toes, between the toes where the bones protrude. So question arises, why our borders authority asked me to deliver some speech regarding ulcer? Because ulcer is our concern. So why ulcer is our concern? Answer, 25% of diabetes patients will develop a foot ulcer, and of the 25%, 48% of this ulcer will become infected, 25% of those will become deep, and 50% of patients with cellulitis will have another episode within 2 years. 25 to 50% of diabetic foot infections lead to minor amputation. 10 to 40% require major amputation. 10 to 30% of patients with diabetic foot ulcer will go on amputation. And amputation in every 30 seconds. So During my presentation, we lost already several patients' limb. And the commonest amputation is below knee amputation, that is 20%, and also multiple digital amputation, that is almost 20%. So number of amputees by age group, usually 71 to 80 age. At the age of 71 to 80, the amputation rate is 21%, and between 51 to 60, the amputation rate is higher, and 30% among the 41 to 50, that is also 30%. So the question arises, we are happy that after sometimes patient visited to us, we told him that you should go for a amputation because life is important than the limb. The patient we counsel in that such a way that your limb is not so important like your limb. So you can sacrifice your limb. But the data shows that mortality after 1 year was 34%, after amputation. Of them, 17% after below knee amputation, 39% after trans knee amputation, and 54% after above knee amputation. Because this type of amputation, whether below knee or above knee, invites huge morbidity for a patient that leads to mortality. So if a patient lost his limb, this creates a threat to his life also. So who are at a high risk foot patients? Usually long duration and uncontrolled diabetes mellitus, peripheral neuropathy. This is very much important because patients are most of the time are not aware of their foot injuries. Peripheral vascular disease, this is the most common cause. And because all the times diabetic patients or hypertensive patients or smokers or any other patients, even he has a trauma or ulcer or obesity or occupational hazards, lack of education, all the times the main culprit behind this non-healing ulcer is vascular impairment. So the question arises, peripheral vascular disease. And you know, peripheral vascular disease comprises peripheral arterial disease as well as peripheral vascular disease. So the grade Wisner's grading of diabetic foot lesions: grade 1 no ulcer but high risk foot, grade 0, and grade 1 superficial ulcer, grade 2 deep ulcer but no bony involvement, no abscess, grade 3 deep ulcer with abscess or bony involvement, grade 4 localized gangrene, toe or heel, and extensive gangrene. Stages of ulcer development, basically diabetic ulcer, callus formation followed by subcutaneous hemorrhage followed by breakdown of skin, that is ulcer, and ultimately extension of the ulcer with ultimately osteomyelitis is the fate. So, what are the activities in our vascular surgery department of the Ibrahim Keita Hospital and Research Institute? That is the most important sister concern of BEDAS. We have a diabetic patient checkup plan. All the diabetic patient we asked to visit our vascular surgery department, whether any vascular impairment or not. That is mandatory for the healthy foot. And we do clinical examination by history taking and clinical exam. And we have the facilities of ankle brachial pressure index measurement, which is the ECG of foot. We have vascular duplex, latest vascular duplex machine is available in our setup. We do conventional angiogram, and with the help of our radiology department, we do CT angiogram, CT venogram, and yes, of course, we have the facilities of BARDEM for MRV, that is an MRA also. And we have the facilities of endovascular management. You know, cardiologists are known as interventional cardiologists. With the vascular surgeons, we do stanting in the cath lab, and our another identity is we are the endovascular surgeon. That's why my identity is vascular and endovascular surgeon. So we are doing all kinds of vascular surgery available with our resources, and also we are doing prostaglandin therapy. We do several workshops on stem cell therapy. This is our dream. We are not doing regular basis. Inshallah, in future we'll do stem cell therapy on regular basis. We are doing some negative pressure dressing also, and we have some collaboration with our other foot care unit and all the allied experts, because you know this is a multidisciplinary approach. Without the help of the general surgeon, orthopedicians, endocrinologist, or other expert, we cannot fulfill our dream. We cannot treat our patient in a proper way. And this is an excellent way for the management of venous ulcer is 4-layer bandage. This is available in our department. And you have some idea regarding ankle brachial pressure index. This is an excellent tool that aids the clinical judgment of ischemic leg. This is nothing, just the ECG of leg. And through this ankle brachial pressure index, we can easily diagnose the peripheral artery disease. We can assess the prognosis of disease, and also screening for prognosis atherosclerosis. And we have two methods. One is conventional method for a BPA measurement. Another one is automated method. Our automated machine is under process. At present, we are doing this investigation or examination through our handheld Doppler machine. Soon we will have the automated machine in our department also. And this is the conventional method where we are searching for the automated machine. And this is the interpretation. All of you know about, definitely you have some idea. Ankle brachial index, we can easily assess the ischemic condition of the foot by the ratio 1 normal, 0.921 borderline, 0.729 that is mild, 0.4 to 7 moderate, and below 4 it's severe. Some are do's and don'ts for the management or prevention of ulcer. That is, use mirror to check feet daily, such as bruise, color change, blister, swollen, ingrowing toe. We usually advise our patient, feel that your foot is your face. Just take care of your face, and just please take care of your foot. Use soft socks. Keep on covered with clean dressings. Check inside your shoes for stone sharp objects and rough places before putting them on. Always wash your feet with soap and water. Take care to wash between your toes. Dry your feet carefully, especially between the toes. Use oil or lotion to keep your skin soft. This is important for prevention of ulcer. And also cut toe nails straight. And always protect your feet by wearing suitable footwear, and have your feet checked periodically by a healthcare professional. And please don't let your feet get dry and cracked. Don't walk barefoot inside or outside. Don't use water that is too hot to wash your feet. This is very much common in our country. Most of the time people comes with a injury with new shoes, hot water or cold water. And don't wear tight shoes. Don't wear tight or knee-high socks. Don't use a heater or hot water bottle to warm your feet. And don't depend on antibiotic only for the management of ulcer. Most of the time people are getting several antibiotics for the long time for the treatment of ulcer. Most of the time local wound care with revascularization is okay for the management of ulcer. And please avoid self-dressing, also work dressing, because dressing is the art of a surgeon, and this will not fulfill by yourself dressing or any quack dressing. And please, before doing any amputation, please assess the patient whether there is any vascular impairment. You can assess it clinically or by duplex examination by your with the help of your radiology colleagues. And what are the roles of a vascular surgeon? We usually clinically evaluate the patient for ischemia. We have some role as a vascular sonologist. Throughout the world. There are some vascular sonologists, but in our country, our radiology department, our radiology colleagues are doing vascular examination. But with the vascular surgeons, we are doing also peripheral vascular duplex examination for our own assessment. And also, is there any problem with the reporting also? And we are the endovascular surgeon. We are doing peripheral angiogram. We are doing all types of peripheral angioplasty with stenting. And we are doing peripheral bypasses, amputations, and also related surgery for the management of foot ulcer. And this is stem cell therapy is our hope. We have done several workshops. And yes, prostaglandin therapy, when there is no hope or no scope of vascular intervention, we suggest for prostaglandin therapy. And yes, a little bit benefit from the prostaglandin therapy. And yes, we have separate room for local wound care of the patient. And this is the performance of our vascular surgery department. Already we have done 98 bypasses or the Y-graft bypass, that is both the common iliac artery was occluded. That's why we use a artificial graft to bypass aorta to both femoral artery. This is the graft is look like Y. That's why the name is Y-graft bypass. We did several 85 cases of femoropopliteal bypasses, fem crossover bypass. When there is no options for bypasses, then we do extra anatomic bypass, that is femoral artery to femoral artery bypass with the artificial graft, and also the another extra anatomic bypass, which is a sophisticated operation, that is axilla to femoral artery bypass. We have already done 2 cases, actually 3 cases we had done already. Uh, and amputation already had done 209 cases of amputation and several on debridement. And we have already done several cases of cath lab procedures, and we are getting scope in our cath lab together with our cardiology colleagues, and we are doing some angioplasty with a stanting. Already have done 78 cases of angioplasty with several procedures of vascular program. So what we do actually, we evaluate the patient by clinically or by duplex examination. Then we do peripheral angiogram or angioplasty. And for the revascularization purposes, we do peripheral bypass and arterectomy. That is, in arterectomy, that is the removal of plaque. And patch angioplasty, when there is a short segment plaque, we do patch angioplasty, or we do endarterectomy and also prostaglandin therapy. And steps of management in our department to manage the case of ischemic ulcer, that is the clinical assessment of vascularity of ischemic ulcer. First, we assess the vascularity, then we confirm our assessment by duplex or angiogram, then we plan for revascularization either by endovascular technique, or first choice is endovascular technique, that is angioplasty or stanting, and followed by, if stanting is not possible or opportunities is not available, then we do open technique, that is in arterectomy, patch angioplasty, jam graft is in there if there is any short segment lesion, and also peripheral bypasses, even distal bypasses. When revascularization is not possible, we advise for prostaglandin therapy or stem cell therapy, even together with negative pressure management, that is local lone care. And this is a duplex machine by ZE. This is the latest duplex machine, and we are really thankful to our Borders authority, particularly our honorable CEO sir, to gifted us with this duplex machine. And to me, this is my stethoscope, and this is very much important for a vascular surgeon, and I love to work with this machine. And this is the Y graft, just image of this Y graft, outer to both femoral, and this is the patient of after Y graft bypass, that is aorta to bifemoral, and this is the real picture of our patient, and this is the artificial graft to bypass the vessel, and this is the see the tortuous line from axilla to groin, and this is the artificial graft, as the patient is not fit for abdominal big operation, we do axillofemoral bypass, and after this operation he was doing good. And before concluding, just take a home message. For proper management of foot ulcer, multidisciplinary approach is needed. So please, if any vascular impairment during your practice, please consider a vascular surgeon first, whether he needs vascular intervention or not. And special thanks to Brachial Hospital and Research Institute and Borders, and all the doctors of Bangladesh who have some faith over our management. A good day. Thank you all.